In this video, I will cover two causes of tightness and tension in the traps that are not directly associated with dysfunction in the trap muscles. Expect to learn the following: the importance of being able to know why a symptom of tightness occurs, why do the trap muscles rarely experience issues, and two common causes of trap tightness that are not directly related to the traps. For those of you who don't know me, my name is Dr. Matt Maggio, and I am a soft tissue injury treatment expert, specifically for chronic neck, shoulder, elbow, and wrist pain. My focus is on finding and fixing nerves that get stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain without the use of drugs, injections, or surgeries. This leads to a significant increase in overall functioning, flexibility, and long-lasting pain relief. I'm also the creator of the Peak Method, where we teach overworked manual therapists a new injury treatment system that eliminates the frustrations of not getting consistent results, allowing them to reduce their treatment times by at least 50% and easily double their income. All right, so let's get right into the video. Tight traps, tension in the traps, knots, everything across the board. Most of the time, it really isn't a problem with the trap muscle itself. And here's why. So the trap muscle is really, really big, very powerful, does a lot of functions, and it actually has a really good blood supply to it. So when muscles are really strong, they have a really good blood supply, they actually don't develop a lot of what's called the adhesion. I talk about this all the time. Adhesion, also known as scar tissue, basically like glue that gets inside the muscles. Makes it hard for everything to be able to stretch and move how it's supposed to. I believe it is the number one cause for decreased flexibility, pain, and weakness in the body. It's also the most fixable as well with expert evaluation and treatment and palpation, which is a lot of what I teach and try to share with the Peak Method. And it just really doesn't tend to have a huge problem in it. But where the client is often feeling pain or dysfunction, a lot of times it's actually coming from different structures. So that's what I really want to cover in this video. So one thing that I always start with is taking a thorough and in-depth history. One thing that I teach is the importance of critical thinking, being able to problem solve and know exactly what's wrong with the client. I always say, if you don't know what the problem is in the first place, there's no way that you'll actually be able to fix it. So many people out there are just what I call treatment junkies or treatment monkeys, where they just want to jump right into a treatment. They're like, oh, the client presents with this, I'm going to do this. They don't really want to think. But when you slow down, you collect data, you can really get to the root cause of what's going on and do a more effective treatment, a shorter treatment, and one that actually produces long-lasting results, because that's what it's all about. So usually on a initial history, I'm asking a series of questions, anywhere from like 12 to 14 questions, very in depth. I like to do this before I ever do an evaluation or even bring the client in, because it helps me collect a lot of data, slow down, and start to think about what's going on, because there's potentially 7 problems that can be linked to an issue, especially with a musculoskeletal injury. There could be a bone problem, cartilage problem, disc problem, ligament problem, nerve problem, soft tissue problem, and a tendon problem. And we always want to know all the factors in there. A lot of us as manual therapists really default back to it's the fascia, it's the soft tissue. We don't really consider the other things, but all of them really matter. So some really important things that I look at in my own practice and what I see is age. I tend to like to see clients anywhere from like age 25 to about 60. That really keeps me in my wheelhouse of what I see. And a lot of their issues tend to respond more to conservative care and soft tissue based type treatments, as opposed to someone that's older. And a lot of times if I get a younger person in, usually there's something weird going on there that is causing the issue. And it's not like an adhesion buildup. And then as they get into the older ages, like 60s, 70s, a lot of times that degeneration is just so far gone. And sometimes they might just be kind of set and stuck in their ways and don't respond as well to the treatment. So I really like to stay in that like 25, 55, maybe 60 if they're actually taking care of themselves and they're healthy. Next thing we always look at is like, where do they feel the pain? It's very important to know where the pain is. It gives us an idea of what's going on. Then we also look at the quality of the pain. And I always give them a list. I'm like, is it sharp? Is it dull? Is it aching? Is it throbbing? Is it stabbing? Is it numb? Is it tingling? And it's burning? The quality really gives me an idea of which of those 7 problems are really contributing to the pain presentation that they're having. Next thing I always look at is the intensity of the pain. I always give them a scale. I say on a scale of 0 to 10, 0, no pain, 10, you wouldn't even care if we cut that area off. Like, what's the worst that pain has gotten? Really gives me an idea of what I'm dealing with and what type of structures I'm going to look for. Next thing I want to know is there something that can actually make it worse? Is there some, I call it like provocative? Is there something that can reproduce that pain? I want to see that in there where like, hey, maybe they're normally living in like a 5 or 6, but if they sit at the computer for too long, it might get up to like a 7 or 8. That's really important to me to know that it's more musculoskeletal in nature and things that we can actually treat conservatively. I also want to see, is there something that can make it better? I want to see like, hey, if I'm at a 5 or 6 and sitting at the desk all day, I can take a break and lay down, maybe do a stretch or breathe, and it goes down a little bit. I want to see some of those components because one thing that can really red flag a presentation and see this, and I've caught it over the years, especially with some cancers and some bone diseases, where the client's like, hey, it pretty much feels the same all the time. It hurts all the time. Nothing makes it worse. Nothing makes it better. It's just always there. I've caught some cancers over the years, which is really important as well, because early detection on that is really key to doing that. And a lot of times, imagine if you got in there and you did all this treatment, but you missed that because you didn't actually take a thorough history. This really helps clean up the whole process and gets you on a path to really figuring things out and not just stuck, kind of winging it and, trying to be like, hey, I don't really know what's going on, but I'm gonna try a bunch of treatment and see what happens. How's that working out? Next thing is I want to know, is there accidents or trauma? I tend to not to like to treat injuries that come in that were like direct traumas, like car accidents, falls, things like that. They tend to not respond as well to conservative care. Yes, they still need treatment and they need the soft tissue cleaned up and functioning better, but it's just not going to be as successful of a case. So I really like to see where kind of like overuse repetitive stuff, not like a direct trauma, that really responds better to the care. And also just want to know, like, what do they do outside of their job? Are they, beating the hell out of their bodies? Are they doing a lot of crazy stuff? What do they do for work? Are they stuck at a desk all day? Are they doing a manual labor job where it's like, no matter what we do or what they're doing with their activities of their lives, we're never going to get them better because they continue to do more and more and they're just going to continue to get injured. And I don't want to participate in a failure, and the client doesn't either. So if they're going to continue to do all the dumb things that got them in that place in the first place, I don't take them on as a client because they're not going to get any better. That's just insanity trying to change it and not changing anything and hoping it'll just get better. So one of the first and most common causes of tension, like in that trap area, specifically, I see it more in like the lower part here where the levator comes in. You got the rhomboid across, and then you have the trap that comes in there as well. You even got a little bit of the cervical erectors that come down there too. Is the spinal accessory nerve gets stuck. Now, the spinal accessory nerve is one of the cranial nerves. It's one of the only few that actually leaves like the brain stem and comes out to the rest of the body. It's strictly motor for the SCM and for the trap muscle, basically helps move it. But what happens over time with poor posture, activities, and all sorts of things, just living modern life, is all those muscles around there accumulate that adhesion. Eventually it gets stuck to the nerve and creates an entrapment where the client will like really point to like a knot, that knot they talk about, or that tension in their neck. A lot of times is that accessory nerve entrapment. That's where you're going to feel that symptom location. Quality, usually when it first starts off, it's like numb, aching, burning, a little bit of tension and some pain. As it progresses, you might feel like more intense in the tension, but a lot of times you're going to see some biomechanical distortions where maybe their shoulder rolls up or rolls forward because the body's really trying to unload that nerve entrapment. Because if the nerve entrapment is stuck and causing issues, it's going to cause problems across the board. Next is symptom intensity. Usually these are anywhere from like that 3 to 7 range, especially when they're kind of newer from there. I will see like an 8 or 9 sometimes if they've had like a really heavy day where they're on their phone and they're stuck doing stuff all day long. That can actually cause some issues in there as well. I definitely see this gets worse with like prolonged sitting, prolonged device use, and things like that. That can definitely cause some issues in there as well. And then what makes it better? Usually just taking a break, going for a walk, breathing, doing some stretching, laying down for a little bit will usually take some of the pressure off of there as well and bring it down a little bit in that overall intensity. Also, you could just see a history of trauma. Maybe they had some car accidents and things like that that can cause some issues in there where more adhesion forms into the muscle, and then that gets stuck to the nerve as well. But very, very common. I would say this is probably the most common nerve entrapment in the body. There's over 156 different places where nerve entrapment can occur. And in modern society, I'd say this is like number one that's out there that gets completely misdiagnosed and mistreated when someone actually does find it. And then just with whatever they do with their everyday activities and recreation, if they're beating the hell out of their bodies with crazy workouts, not moving enough, all sorts of stuff, they're going to accumulate this. I'm basically anyone that lives in Western society and has some neck pain and neck complaints enough where they'd reach out to you to come in to get this looked at is probably going to have an accessory nerve entrapment. So we have a whole treatment protocol for all that. I'm not going to put this in the whole video, but if you go and download our free training course, we actually have a whole module in there, which is just on the accessory nerve, go through advanced palpation, function, clinical signs, treatment demonstrations, and everything like that. Because when most people encounter an accessory nerve entrapment, they actually think it's like a trigger point or something going on in the muscle itself, and they treat it incorrectly. Nerve entrapments are really finicky about how they get treated. They need just the right amount of depth, just the right amount of tension. And I really show that in the free training. All the links to that is wherever you're consuming this. You can go in and download that, get instant access to that right away, and really start to learn how to approach and directly treat that accessory nerve entrapment. Next area that causes a lot of tension in the traps in the upper back as well is actually what's called a sclerotome pain referral. So inside your neck and your spinal cord, there's different areas of the body that are controlled by certain areas. And when those areas actually get inflamed, especially in the discs, they can kind of radiate pain out to different areas. You can see in through here, we have all these different places where all these cervical discs can go. And a lot of times I'm going to see this in a more older population as time goes on. They tend to get more degeneration, specifically in the disc. But really, in all honesty, I'm seeing this more and more in a younger population. I'm seeing this in like teenagers, people in their 20s and their 30s, because they've just spent so much time on their devices and their phones that they are presenting with like some really massive disc bulges and herniations and all sorts of things. So it's actually a lot more common in a younger population than maybe it was like 20 or 30 years ago. Symptom location just depends where they're feeling it. But I have one of these charts in my office, and it's really good to refer to as well. I'll even show the client and be like, hey, kind of point to where you're feeling it. It'll kind of help me isolate which disc area is inflamed and where I need to go treat. Severity, a lot of times with these ones are pretty bad. They might get some episodes of like an 8 or 9 out of 10. And they might say, I woke up and couldn't turn my head. I just felt like crap. It hurt like I was breathing. Some people would say it feels like the rib's out of place. The rib didn't go out of place. They're actually feeling these sclerotome referral patterns in there, and can get really intense at times, especially when that disc gets injured. The disc does not like to get injured, creates a lot of inflammation, a lot of pain, discomfort. Symptom quality, more of like a sharp stabbing, shooting type of pain, going to be a lot more intense in there as well. Usually what makes it worse is people tend to usually feel a little worse when they first get up in the morning, because that disc is kind of settled a little bit overnight and it's a little bit bigger, and then there's more inflammation in the morning, and then usually they feel a little bit better as they get up and move around. Then it's kind of beat up again by the end of the day where that inflammation comes in. And usually, yeah, when they get up and move around, they get hydrated, they go throughout the day, it's not as bad, but then it's really beat up again at the end of the day and can cause a lot of issues in there. Big thing here was just, accidents, car accidents and falls and things like that. But I'm also seeing this with just repetitive overuse stuff. So when you have all that adhesion in the muscles and it gets stuck to the nerve, the force has to go somewhere. So it ends up going to the discs and the joints, and then the joints get really beat up as well. So you can see this a lot in people that may have not had any direct accidents or trauma. And they're like, holy cow, how did I get degenerative disc disease? I didn't even know that I had this in there in the first place. And then also just what do they do for recreation and activity? Are they beating the hell out of their bodies? Or in a job where they're just ranking on their neck all day long? That's going to put pressure on the discs as well. So how would we actually treat this? Really what we need to do in this portion, when we're thinking that it's more of that sclerotome referral pattern, especially with the intensity, the quality of it, maybe the time of day factors, worse in the morning, worse at night, better with use and stuff like that. What we really need to do is we need to decompress the disc. And that starts by getting rid of all the adhesion, using a manual and instrument-based approach. We usually go through the ligament first in the neck, then the levator scap and the nerve roots and the scalenes. Then we're also really just trying to reduce the daily load on the tissue, like explaining to the client, hey, you're doing too much. You keep getting overloaded. I need you to watch your posture with your phone. I need you to take breaks throughout the day. I need you not to be buried in your phone all day long. I need you to get up and be a human and try to walk and drink water and do all that stuff. Things they got to do in between as well, because a lot of times the client's just like, hey, here's my problem and you fix it. I'm not going to do anything in between. It's like, no, I'm here to help, but I'm not going to carry you up the mountain. And then lastly, once we get rid of all the adhesion, we get things functioning better, they're doing better lifestyle things, we start to strengthen the front of the neck with this exercise. I call it a QCR. It basically strengthens the anterior part of the neck. The neck has a core just like your lower body, and those muscles just become really deconditioned. The problem is if you try to like fix the posture or you're trying to strengthen all the muscles before you get it healthy, it's going to be counterproductive and actually make that problem a lot worse. Actually, in the second module in the free neck and shoulder training, we actually go through the whole protocol of a disc presentation, what it looks like, what questions to ask, what tests to do, what palpations to do, and what treatments to do as well to really get this moving in the right direction. Because even if they have degenerative disc disease, there's still a lot you can do to go in there and help them. So that's all I got in the video. If you like the video or you got anything out of it, share any insights you might have gotten in the comment section below. Also, you could share it with some other providers out there that are doing good work, that want to get better. Maybe they want to streamline their treatment process a little bit better, do it more efficiently, more effectively, not feel all that wear and tear of doing these long sessions, but more of a focused, functional based type of session. And then lastly, you can go in and download the free training modules. I talk about it throughout the video, but basically we have all of our training is available online, where you go through the neck, the shoulder, the clinical signs, palpations, functional testing, everything you can do to really get to that role of like becoming more of a solutions provider as opposed to a service provider, and cut those treatment times by at least 50%. I appreciate you watching, and we'll see you on the next one. Bye.